Those are the voices of young school children in Uganda, singing a happy song about what's in their hearts. Sadly, in their country and other developing nations, the heart of a child can face an uncertain future from the threat of what in the modern world is considered a curable disease, a strep infection. Hello and welcome everyone to this special edition of Kids Speak Out. I'm Barbara Harrison. Today we're talking about a killer that is ravaging the youth in developing countries around the world because of the troublesome lack of modern medicine. Joining us today is a doctor who decided something had to be done about this devastating problem. Dr. Craig Sable, an award-winning pediatric cardiologist with Children's National Hospital in Washington, D.C. He traveled to one of the countries with a very high death toll from this disease some 20 years ago, and he's still going back today. Dr. Sable, welcome. Good to have you with us.
Thank you, Barbara. It's a pleasure to be here, and it's been an honor to work with my colleagues, such as Dr. Emi Okello at the Uganda Heart Institute for almost 2 decades to try to improve the lives of children and young adults with heart disease, most specifically rheumatic heart disease, through clinical care and research focused on prevention.
And we have Dr. Okello with us today from Uganda, where he specializes in interventional cardiology and is head of the CardioCath lab at the Uganda Heart Institute. He's also involved in research into this disease and oversees the rheumatic heart disease program there. Thanks for being with us, Dr. Okello. RHD is a real problem in your country, isn't it?
Thank you for having me here. I have been working with Dr. Craig Sable and his group for the last 2 decades, and it's been an amazing work to try and solve this problem of rheumatic heart disease. So glad to be here.
And we have another physician with us today, Dr. Dominique Vervoort with the United Nations UNITAR Global Surgery Foundation, joining us today from Canada. Good to have you with us, Dr. Vervoort.
Thank you, Barbara. It's a great pleasure to be here. As a trainee and aspiring cardiac surgeon myself with many years of work and experience in the field of global surgery, it's an honor to be here with you all and speaking about this topic of RHD today.
And we are also fortunate to have joining us from Uganda, Flavia Budarin, a nurse and a former rheumatic heart patient herself. Thank you so much for being with us, Flavia.
Thank you, Barbara. I'm glad to be part of this program as a nurse and at the same time a patient living with rheumatic heart disease.
And our Kids Speak Out crew joining us today are some of our regulars on the program, 4 young people who are part of UNITAR's 1M 2030 project, identifying 1 million young people around the world who show promise of becoming leaders in many fields around the world by the year 2030.
Hi, I'm Charlotte and I'm from Stratford-upon-Avon in England.
Hi, I'm Sam Rose from Bethesda, Maryland.
Hi, I'm Tom from Oxford, England.
Hi, my name is Brooke Hector, and I'm from Sausalito, California.
So, Dr. Sable, let me begin with you. How did you first get interested in global medicine?
As a pediatric cardiologist, I've always been interested in trying to focus on disparities in access to care, especially in those disparities that impact children around the globe. And I had the good fortune of visiting Uganda for the first time in 2003 and seeing something that I never expected, which was this huge burden of rheumatic heart disease, a problem that should be completely preventable. And while my initial goal was to help to expand cardiac surgery services to treat those with advanced valve disease, it soon became apparent that the problem was so much bigger and that the only hope was to develop innovative research solutions that would lead to prevention of the millions of children that were suffering from this disease.
Dr. Okello, were you aware before studying medicine that rheumatic heart disease was such a big problem in your country?
No, because nobody was talking about it. And this didn't surprise me when I got to know that part of the problem was awareness and sort of political will and will of people who could do something about it, until a few others before me and our generation started looking at this as medical practitioners. And with our international collaborators like Dr. Craig Sable and his many excellent colleagues, saw this as a problem that could be solved. And our resolve made 10 years ago was that we should eradicate rheumatic heart disease in our lifetime.
Now, Flavia was an RHD patient. Was she one of your patients?
Flavia was first my colleague, and we worked, for over 5 years without knowing that she had rheumatic heart disease. And then when she had one of her pregnancies and she went into labor, then we were made to know that she was going into heart failure. So you can imagine how we felt that this hardworking nurse colleague was coming down with heart failure, which is our calling, which is what, we spend our days treating patients with heart failure. And we're happy that Flavia did well, and she continues to work with us as an advocate as well as a nurse practitioner.
Flavia, maybe you can tell us, what are the symptoms of this disease?
I lived a normal life. I didn't have any problem, not until I got pregnant. And I carried the pregnancy very well. But after delivery, I failed to breathe. Moving the shortest distance would look like the longest journey. I would feel so tired easily. And I couldn't breathe well. I couldn't sleep flat. Everything was so hard for me.
People think surgery is the only answer, whereas in reality, if we can focus on the origins of the disease, namely strep, with solutions that could include a vaccine, and even earlier, overcrowding and poverty, which obviously we all would like to try to think about overcoming. Our goal is to find children in the earlier mid-school age years where the disease is very early in its course, and giving penicillin can prevent it from progressing to the point that it causes heart failure, like it was the case in Flavia's situation.
I want to ask Dr. Vervoort, are you looking for ways to avoid surgery, even though you are with the Global Surgery Foundation?
I think that's a great question. And I think regardless of my affiliation and my personal interests within the field of cardiac surgery, I think with any given condition, whether it's rheumatic heart disease or any else, the main goal is really to prevent disease. And the main goal ideally is for surgeons to be without a job.
I had a question for Dr. Sable. My question is that with the figures that Dr. Okello gave of the amount of children that don't know that they have rheumatic heart disease, do you think that mandatory heart checkups should be instated worldwide?
Thanks, Charlotte. That's a really important and great question. And we've looked at that issue and tried to figure out who are the best children to screen for heart disease and when should they be screened. In Uganda, which has a population of 40 million, there's probably up to 15 to 20 million of school age, and screening all of those children may be very difficult. But perhaps if we could pick a certain grade that's at highest risk, such as kids in 3rd or 4th grade or 10 to 12 years of age, that may be the ideal.
Is this like particularly prevalent in Uganda? Is it like a localized issue, or is this wider on the continent?
So rheumatic heart disease is highly prevalent in most of sub-Saharan African countries, and there's still high prevalences in Southeast Asia and I think the Mid-East Asia somewhere. Those are the countries with the highest prevalence of rheumatic heart disease, and in some countries of South America as well.
I want to ask Dr. Sable, what are the numbers now and how have they changed in the 20 years since you and Dr. Okello have been working to treat kids early?
The current estimate that there are about 40 million people living with rheumatic heart disease in the world, and that's about 5 million more than HIV. Rheumatic heart disease causes just over 300,000 deaths per year, and really most of these should be preventable. The problem is that it's complicated and it's hard to generate will around the world to face this problem.
I have a question that anyone can answer, but is it more common in girls or boys, and why is that?
I may ask Flavia to say a few words about this also because of what she's gone through. So if you look at the early stages when people are 8, 10, 12 years of age, there's probably the same number of boys and girls that get rheumatic heart disease and rheumatic fever early on. But in terms of suffering complications, it diverges, and the number of women that have devastating complications is far greater than men, in part because pregnancy drives the progression of valvular damage. And Flavia, I'd love to hear your thoughts.
Actually, in regard to the sex disease affecting the people, when I was doing my study for my master's program, I discovered that rheumatic heart disease is more prevalent in women, and this is related to genetic factors. But also, given that women in their adult life, they go through the stages of delivery, so they are more affected and they get more complications than men who have to just live their lives without any interruption compared to women.
Flavia, I had a question about, from your own personal experience, how important it is to prioritize RHD kind of on a medical basis.
It is important because rheumatic heart disease is so devastating, and when it affects one person, it drains the family because it is like a long-term care. And when one person in the family is affected, that person there are a lot of resources spent to care for the person medically, and then their quality of life is reduced. They are less productive because those people who are in advanced stage, they can't contribute, they can't work.
Sam Rose, who is also with us today, launched a project along with his brother to build a well in an African village that needed water. He did very well with that project, just going door to door and getting friends and neighbors to donate. Sam, I want to ask you, do you see this as a way that you might be able to raise funds for more RHD research, or perhaps to send more penicillin to countries like Uganda?
Yes, I could see myself getting involved in that, especially since a lot of rheumatic heart disease is caused from strep, and they get the strep from the dirty water. So if we can eliminate the dirty water problem, I think that can definitely decrease the amount of people who get rheumatic heart disease as a child.
I've got a question that could be for any of the doctors. You told us about how I've identified genetic and gender-based and also poverty as risk factors. Have you been able to use those risk factors you've identified to sort of see which people, which demographics might be more vulnerable or more susceptible to the disease, and therefore work out who needs to be treated or scanned and that kind of thing?
I think the overwhelmingly highest risk is the poverty and overcrowding. So for sure, focusing on areas that are most impoverished in the world, what unfortunately is 80% of the planet and 2 billion children, we know they're at highest risk. That doesn't help in narrowing it down very much. We are working, and this is more of a research question, about looking at ways for genetic testing or using other biologic markers to focus in on, can we think about screening a smaller number of children by focusing the screening.
What do you think the role of surgical care is in the light of the millions of people who live with RHD today?
Thank you, Charlotte. That's a great question. I think we've talked a lot about the issue of prevention, which obviously for rheumatic heart disease and some other surgical conditions is really the first thing that we should emphasize, because the main goal is to reduce the burden on patients as well as in the health system as a whole. But unfortunately, with the fact that still dozens of millions of people live with rheumatic heart disease, with the fact that rheumatic heart disease is a condition of poverty and will likely continue to exist for many years, if not decades, the treatment thereof and surgical care for patients who require surgical care for rheumatic heart disease will be something that will continue to be needed in years to come. So the real goal is to embed that within the broader health system to ensure that patients who require surgical care have access to all the healthcare services that they need to actually manage that condition holistically throughout their lifetime.
How hard is it to get penicillin in these countries that struggle with rheumatic heart disease? And if it's not already there, how hard would it be to transport it to them?
Penicillin is widely available. Sometimes we get stockouts when we don't have penicillin in the country, because the original ingredient, I think, is being made by only one company in China that then exports to the rest of the world. But we have been working with the World Health Organization to make sure that penicillin is available. And so I can answer that. It's relatively available.
Dr. Barut, should the global discourse surrounding RHD only focus on prevention?
The management thereof, both pharmacologically as well as surgically, will be something that will continue to be needed. And so within kind of the global discourse of rheumatic heart disease, while prevention should be emphasized and should be prioritized, we can also never forget about the fact that the tens of millions of people who live currently with rheumatic heart disease will continue to require treatment currently as well as throughout their lifetime as they live and struggle with rheumatic heart disease.
How has COVID affected rheumatic heart disease?
COVID has dramatically impacted patients with a wide variety of diseases other than COVID in terms of limiting access to treatment and diagnosis for very many important diseases, both in the United States and low-income countries. Specifically in Uganda, we were really fortunate to have a great research infrastructure and very creative team that was able to continue all of our research despite the COVID pandemic.
To any of the doctors, what can we do to help, sort of, as people who are not living in areas affected by this, and we've got the privilege to not have this problem ourselves? How can we help, and how can we get involved?
Thank you, Tom. That's a really important question, and I think we've talked about this already. The idea of raising awareness about rheumatic heart disease in all walks of life, whether it's school children in Uganda who are learning about how to prevent strep throat, or people in the United States who are more focused on problems that are closer to home. And if we can think about solutions to eradicate strep, whether it's a vaccine or early detection and prevention with penicillin, we're not only going to help prevent millions of cases of rheumatic heart disease, but we may affect tens of millions, if not hundreds of millions of people in the United States whose lives are impacted by getting strep throat.
Thank you, Dr. Sable. This has certainly been an enlightening discussion today about rheumatic heart disease. And I want to thank everyone on our panel, Dr. Emmy Okello, Flavia Buterin. Thank you both for joining us from Uganda. Dr. Dominique Vervoort, thank you for joining us, representing Unitar's Global Surgery Foundation. And we want to thank our 1M 2030 panelists, Charlotte, Brooke, Sam, and Tom. And thank you again, Dr. Craig Sable of Children's National Hospital in Washington, D.C., for bringing us this story about the struggle in many developing countries to save the lives of thousands of children who face the deadly consequences of rheumatic heart disease. For all of you out there, thank you for being with us. If you'd like to help, go to our website, kidsspeakout.me, and look for the donate button for Children's National Hospital. Thanks for watching, and join us for our next episode, where kids speak out about ways to solve the world's big problems.